Hello, everyone. Welcome to PAMI's webinar called Turning Insight into Impact, Using Evidence to Expand Access to Seizure Alerting Devices, where we'll have an important conversation on the evolving role of wearable and non-invasive devices in epilepsy care. We'll get started in just a minute. We want to let people file in, but we'd love to see where everyone is joining us from. So if you are comfortable to share your city and state in the chat, please do. We'd love to see it. Another note that we welcome your questions during the webinar, so please submit them in the Q&A box, and we will set those aside for our panelists to answer during that segment. Just as a reminder, we're not able to give specific medical advice, so please keep your questions general in nature. If you have questions specific to yourself or your loved one, make sure to ask your healthcare team. And with that, I think we can get going. Thank you, everyone, for sharing your viewing location. It's great to see people from all over the country. Just a few housekeeping items before we get started. We talked about the Q&A. We also encourage connection. So if you want to use the chat to connect with each other, please do. And then last note that we're going to record today's webinar, and it will be available in about 24 hours, and we'll send out an email to share that link once it's available. So with that, you want to thank the sponsor of today's webinar, who has generously underwritten the cost of this webinar. Thank you, Cass, so much for your support and for making the impact that you do on education within our epilepsy community. So our panelists, we're grateful for our speakers who are with us today, and I'm going to introduce them to you at the outset. I do want to mention this is our largest ever registration for a PAMI webinar, so we're excited about that, and I really think it speaks to the interest and the need within this device space. During this webinar, you're going to hear about key findings from a national survey conducted by the Epilepsy Foundation of America and the Danny Did Foundation and many other advocacy groups that shared the survey about the use of devices. And we're going to look into how these insights are helping to shape a professional guideline that recognizes the value of device use in epilepsy management. So this type of guideline can be a powerful step towards enabling insurance coverage and improving access to these technologies. So the goal is that the survey can help get us to the guideline, and the guideline can get us to some type of insurance coverage. So we're hoping that you'll leave today learning about how data and advocacy and community voices are coming together to drive real, tangible change for the epilepsy community. And to help us do that, we have Tom Nugent. Tom and his family are managing epilepsy because they have two adult sons who are affected by the condition. Tom's oldest son, Will, is diagnosed with Lennox-Gastaut syndrome, or LGS. Over the course of Will's 22 years, the family has explored more than 20 medications, experimented with various diets, and undergone several surgeries in their efforts to reduce Will's seizures. Throughout this journey, they have relied on multiple seizure detection devices and continue to search for new technologies to monitor Will's condition. And from the Epilepsy Foundation, we have Dr. Caitlin Griskowiak, who is the Chief Research and Innovation Officer at the Epilepsy Foundation. In that role, Caitlin leads EFA research initiatives, which include the Research Roundtable for Epilepsy, the biannual Epilepsy Pipeline Conference, the Epilepsy Foundation Shark Tank Program, the Accelerator Course for Epilepsy-Focused Startups, and Next Generation Clinician and Scientist Fellowships. So Caitlin has been with the EF for since 2020 and we're grateful to have her with us today. And finally, Teresa Prego is the Chief Executive Officer of EpiWatch, which is an innovative company bringing continuous seizure monitoring, detection, and alerting to individuals and families living with epilepsy. EpiWatch is a FDA-cleared software as a medical device platform, which runs on Apple Watch, and it provides real-world objective seizure data that improves safety, care management, and ultimately risk forecasting and precision medication for epilepsy. Her passion is in utilizing innovation to create improved care solutions and expand access to care. So we'll be excited to hear for all of them, and we're grateful that you're taking part. First, we want to start with Tom, and then we'll hear from Caitlin and then Teresa. So a reminder, please use the Q&A box as we hear from our speakers, so you can have your questions captured, and then we'll address those during the Q&A towards the end. Okay, with that, I will turn it over to Tom Nugent.
Hi, thanks, Tom. Thanks for the intro, and thanks so much to Pammy for the opportunity to share our story. So I'll start out with a quick background on our family, then talk about specifically our experience with seizure monitoring devices. As Tom had mentioned at introduction, we do have a long family history dealing with seizures and epilepsy. We have 3 boys. I call them boys. They're actually young men, would be a better term. In this picture here, you see our middle son, William. He does have a severe form of epilepsy, Lennox-Gastaut. William is turning 23 soon, and he's been dealing with seizures really his whole life since he was about 6 months old. Seizures have been a constant in his life. We've really experienced just about every type of seizure with William. Myoclonic seizures, absence seizures, tonic-clonic, drop attacks, you name it, we've kind of experienced it. We've tried 21 different medications for Will, had a couple different surgeries, we tried different diets, yet we're still dealing with multiple seizures every day. We did have a surgery in 2011 that was very helpful. So prior to that, we were having really hundreds of myoclonic seizures every day with William. And after this surgery, we're down to about 4 or 5 kind of typical tonic-clonic that last maybe about 30 to 45 seconds. So quick background on Will with our son Quinn, who's 27, and he's in this picture on the left side. Quinn also has epilepsy, but a much different form than his younger brother. Quinn has had about a dozen seizures in his life. The last one when he was 13. We feel his type of epilepsy is tied to his childhood, and he outgrew this once he hit his mid-teen years. And then our oldest son, Jack, on the right in this picture, he's currently working in neurocritical care medicine at the University of Cincinnati Medical Center. And his experiences growing up with 2 brothers who are dealing with epilepsy obviously was a driving force in his choice to enter the medical field as a career, and also to specialize in neurology. So getting into the specifics, and I'm really going to focus on our son, William. As I said, we've been dealing with epilepsy his whole life, and we've tried a number of different devices. But early on in his life, probably like a lot of people, we just used a baby monitor. So it was just a sound monitor and listened to any kind of activity at night while he was sleeping. And, we used sound monitors for about 10 years with William, his first 10 years of his life. And that was a really, really difficult part of our journey here with epilepsy. You hear a sound, you get something out of that monitor, you hear a sound. One of us, either myself or my wife, would rush into his room to check on him. A lot of sleepless nights. He was having a lot of seizures at that time. If he was having a rough night, one of us might sleep on the floor in his room. We might have to bring him into our room and someone else go into his room. Just really, really difficult. A lot of stress dealing with these, just, not knowing what's going on at night. I mean, we have our youngest son, and we're concerned. We know he's having a lot of these seizures during the day, but what's going on at night? So just a really, really difficult part of our lives back then in dealing with his epilepsy. In 2013, we did work with the Danny Foundation to procure an MFIT monitor. So the infant monitor is a device that goes in a bed, kind of under a mattress, and it detects movement at night. And then it could sound off an alert based upon those movements. And we recall the first night we installed the infant monitor, an alert went off. We went into his room and he was having a seizure. So that gave us a significant peace of mind at night that, hey, if something did happen to Will, the monitor would go off, set off alert, and we'd be able to take action if needed to help him. So we did use the infant monitor for about 5 years. And there were maybe 20, 25 times during that period where the monitor went off and alerted us, hey, he's having a seizure, and we can go in and take action from there. There were also a number of other false alarms. I think some of that has to do with William was quite active at night and moving around. Some of that due to the medications he gets, so he's a little too active, and that would have a tendency to trigger an alarm when he was just kind of flopping around in his bed, just doing kind of typical movements, and not having a seizure. So in 2020, we did try something new again. We tried the Miku monitor, and this was a video device. And for us, that was really another step in the right direction, because it really gave us an ability just to, hey, I'm going to use one of these smartphones. I could bring up the app in our phone and to be able to get a video from him. And it was a very clear video to be able to see what's going on in his room. And that device also had a feature in there to kind of track his heart rate, or I'm sorry, his breathing rate, his RPM. So that was helpful as well. So video piece, a huge help. We can check on him just by using an app on our phones, but it also helped in understanding, hey, we did catch some seizures, and the device would be able to, hold a video of that we can view the next day. So by checking that out, we're able to see, all right, what types of seizures was he having at night? Are these in line with what we were seeing during the day? And we found out that these were. So they were kind of typical, 20 to 30 seconds of a tonic-clonic seizure. So that was very helpful in being able to see what happened. But unfortunately, there wasn't really a good alerting system with this particular device. And really, that's a big reason why we started using devices. You want to be able to know, hey, if there's an emergency, he's having a seizure, maybe his breathing goes down. So what can we do to take action to stop that seizure? So some positives with the Miku device, but also in the end, some challenges that we really didn't get that, hey, here's an alert to let you know that something's going on with him so we take some action. So that led us kind of to our next step, and that's using the SAMI monitor. So we just actually started using this about 2 months ago. And like the Miku, it is a video monitor. It does have some more advanced alerting technology with it. The other main difference, the SAMI was really built with epilepsy and seizure detection in mind. So it really offers that ability to set up alerts based upon movements, how long those movements last. And what we found out is Will likes to move around a really lot at night. And most of these are not seizures. So the device does keep a video of all his movements. So the next morning I can open up an app and I can see he's moving around 60 to 70 times at night. Now the challenge there is that we haven't really caught a seizure yet, but we're seeing that, hey, he's moving around at night. So that kind of gives us some insight into what's going on with him. It's kind of hard to look through 50 to 60 different videos to see, hey, was he having a seizure? With the alerting system, with the SAMI, when he does move around, and you can set you can do the settings, hey, it's after 15 seconds, an alert goes off, 30 seconds. Right now we would be getting like 50 to 60 different alerts going off, and that's just not feasible. So we're trying to play around with the settings to figure out what works best for Will. As I said, the device has quite a few settings that we can utilize. So we're just trying to figure out what's the best way to catch a seizure, but not have the alert go off every time he's moving around in bed. So, with these different devices that we've used, I would say it's made a significant positive impact for us. Yes, we don't think we found something that's perfect for William yet, but really peace of mind has been a huge benefit and quality of life in using these devices. I think back to, before we started using devices, and, we did have an overlapping period where both Quinn and Will were having seizures. And we had, just typical baby sound monitors in both of their rooms. Really, really stressful period in our lives where, hey, if we hear a sound on one of the monitors, we got to rush in, look at Will's room, see he's okay. We go over to Quinn's room, see if he's okay. So just not the best way to handle this, and was really stressful and impacted our quality of life without a doubt. So these devices have helped significantly in our quality of life and helping us monitor our boys with epilepsy. So, as I said, they do help with, hey, understanding what types of seizures they're having. That's important, especially for William, because he's had so many different types of seizures. A lot of people probably, if your loved ones, they may change their seizure types during their journey with epilepsy. So it's important to know what's going on with that. Secondary benefit we've received is really, as I said, Will likes to move around at night. Sometimes he stays in his bed. Other times he likes to move around in his room. So just understanding what's going on at night. Will is nonverbal. So we need that video monitor really to tell his story. So that helps us understand, hey, if he gets up at night, can it sound an alarm to alert us? And where's he going? Is he trying to get out of his room? Is he maybe going for a book or a toy in his room? So having that video kind of be able to look at that and tell that story, what's going on at night is very important. And also the mobility of these devices has been a huge help. Will likes to take some naps in the afternoon. We can take the device, move it somewhere else in our house, and be able to still monitor them. If we go on vacation or we go visit someone, we can take the device with us, set it up somewhere else, and still have that ability to monitor Will. So those are all really positives with using these different devices. The big challenge we're still experiencing, though, is that alerting piece of it. And that's really what started us on this journey and looking at devices, is finding something that would alert us if he does have an emergency at night. Can we get alerted to that? So if we need to, we can take some action. So we're still trying to figure out that piece. But really going forward with these devices, I do see just, some really rapid advancements in these technologies. For example, we hear a lot about kind of AI in the medical field, particularly with devices. I'm thinking about, with this SAMI device that we're using, we get 50 to 60 different videos. Couldn't, it's some type of AI system be able to detect, hey, out of these 50 to 60 different videos, which ones more than likely are a seizure? And can that help set off an alert that's more accurate to reduce the false alarms? So that's an important piece to keep an eye on. I hear a lot about, seizure predictions, devices that may be able to predict when next time someone's going to have a seizure. I think for us personally, the wearable is probably something we'll look into. We haven't in the past because Will is, to put it lightly, a little bit fidgety with anyone that kind of tries to do something with his arm. We go to a water park and they put a little thing around your wrist. Will fight that. He'll push back on that. And if you get something around his wrist, he'll try and rip it off. But I do feel, because we know from when he's been in the hospital, that when he has a seizure, there are certain things that happen in his body that change, whether it be his heart rate or his breathing rate. And these wearable devices may be able to detect that. So really, I encourage parents, caregivers, keep doing your research on these devices, reach out to these vendors, check out their websites. One thing that I do quite a bit is the Danny Did Foundation sponsors webinars where they showcase these different devices. It's a great way to learn about what's out there. Being in epilepsy, really dealing with this epilepsy journey for close to 30 years. I know that, everyone out there, all the parents, caregivers, we all have different needs for the people we're caring for. We all have different circumstances. What we do all have in common, though, is to, really try to protect our loved ones from these dreaded seizures. So keep looking, find a device that works best for you. I know with our family, we'll continue to see what's out there and try to find something that is the best for our son, Will. Great. So thanks again to the Pammy for giving us the opportunity to share our story.
Thank you, Tom, for sharing all of that experience. And I know you've tried quite a few different devices with some pros and cons, which is excellent feedback for the community to have. So we appreciate that. Okay, so next I want to turn it over to Caitlin to talk more about the device survey that we mentioned and the results and some of the themes that were found in that feedback.
Wonderful. And I will say you'll see a lot of what Tom has already said. So, Tom, I feel like you really put the color commentary on everything I'm about to tell you. So, thank you for opening with such comprehensive thought and thoughtfulness to this webinar, because I completely agree, and the community echoes a lot of what you brought to this. So, thank you, and thank you to Pammy and Tom for having me speak at this webinar. I'm really excited to share with you some perspectives on new technology from the community. And just to give you a little bit of background, this was an initiative that was really begun out of our effort at the Epilepsy Foundation to offer convenings that people can bring to the table to understand perspectives from lots of different stakeholders. Tom was also kind enough to come speak at that meeting as well. And really the goal is to get folks who are using the devices, making the devices, and Teresa's also on this call, so she'll talk about that too. And also people who regulate those devices and pay for those devices in a room so that we can really understand what are the barriers to getting access to these devices. And so part of that effort, which took a year of planning, was a survey that we put out to the community on understanding of devices, perceptions of devices, as well as understanding use of devices. And so we put this survey out so that everybody could participate and offer their perspectives, with the goal of sharing it at this convening earlier in the year, where we shared it with people who make the devices so that they understood a little bit more of the community perspective. So with all that in mind, I wanted to just kind of start with some understanding of how we got there. So the survey was distributed by the Epilepsy Foundation, the Danny Did Foundation, some of our partners, including the Rare Epilepsy Networks, and we really, as well as a lot of the technology partners who also participate in the roundtable gathering. But the idea was we all came together, we created questions, we put the survey out online, mostly through social media channels and newsletters from all of the different stakeholders. And our goals were really a couple things. One is to understand use and adoption of the technologies, wearables, but also some other monitoring devices, including the SAMI, as Tom said. Understanding where people hear about technologies, and understanding where they want to hear about these technologies, so that we can best find the right places to connect people. And then also understanding where people hear about reasons why they might want monitoring, like SUDEP and nocturnal seizures. And just a couple of important things to note as a sort of from a research perspective. We wanted to just note that a lot of the responses that we collect as part of the way we advertise does impact the results. So in terms of generalizing to the entire community, we also have to just keep in mind that the survey may look very different from respondents who are not connected to some of the places where we put the survey out there. So that's just to say a lot of the people who responded to this survey already know about devices or may already be connected to the Danny Did Foundation, the Epilepsy Foundation, or our partners. But even despite that, we really were very encouraged by the responses and the fact that people were really willing to, if they haven't used technologies, to learn more and to share their opinions. So we analyzed the results only from those who completed the survey. So we had about 1,000 people start the survey, and about half of them fully completed the survey, which was actually quite long of a survey, about 30 questions. And so we just want to say thanks to all the participants who completed the survey and provided us this perspective. So we, again, compiled these results and shared them with the technology developers at the 2025 Diagnostic and Tracking Roundtable that happened in April. So I'm going to share a little bit about the results, and I'm going to start with seizure types and device choice, because really right now when we think about devices and regulatory approvals, we have a few that are approved for tonic-clonic seizure detection, and so that's an important distinction when you're thinking about choosing which device might be right for you. 62% have used a device for epilepsy and seizures, and 38% had not used a device out of the 555 who completed the survey. So it's even amongst the very well-connected population, we still see about 40% of people who have not tried devices, and that can be for a variety of reasons, including that their seizure types may not be detected currently by available technologies. We also ask people to let us know if they reported having tonic-clonic seizures or reported non-convulsive seizures. And some people have both, which is why that number is higher than 100%. But what you can see is the majority of people actually report having tonic-clonic seizures. And then one other sort of distinction that I should have mentioned earlier is that this survey was taken by people who both have epilepsy themselves or are caregivers of people with epilepsy. And the distinction is not in these slides. So this encompasses people who speak on behalf of somebody else, and then also people that use devices themselves or don't use devices themselves. So what you can see here is we also asked people which devices they used, and the SAMI alert was the most popular device, also the Embrace, and then other encompasses a bunch of other groups that were didn't all meet the requirement to be included in the others. But you can see there's lots of places that are working on options for having different use cases for when you might want to have a detection or alerting device. And to Tom's point about deciding which device is right for you, there's lots of considerations that go into selecting each one of these. And people may have more than one. So we also wanted to get a sense of why people used the devices or selected the devices that they did. And so when we subdivided, we said, do you use a device or not? For those who said, I do use a device, we asked them what motivated them to use the device. And again, this is where, and it comes up as an important point later on in these results as well, that this is a combination of people who are both caregivers as well as individuals with epilepsy who might track their own seizures. But for those who use devices, they were primarily motivated by reduced anxiety to the caregivers and alerting. And then that kind of very nicely dovetails with what Tom just said, which is that the reduced anxiety for the caregiver, the ability for the intervention, and then overall safety. That seems like something that we all strive for, but we're very interested in the main motivations. And you'll notice that actually reduced anxiety for the user shows up at about 16% versus reduced anxiety for the caregiver at 65%. And so we then asked people sort of, okay, you answered why you wanted to use a device. And then we asked them, what are the reported benefits of using the device? And you'll notice here that the number actually goes up. So it started at 65% said they wanted it for reduced anxiety of the caregiver. And actually, when they say what actually was the benefit, 71% said reduced caregiver anxiety. And then about half said the alerts for the caregiver intervention and better sleep for the caregiver, which I feel like is a very underappreciated use case and improves quality of life for the caregiver. And that should be we need to do more work to better understand how we can do that. But again, reduced user anxiety was at 15%. So that leads us to believe that there is some more reduction in anxiety for the caregiver versus the user. And then the other important thing that and again, this doesn't give you a length of time, but it does tell you that for the snapshot in time in which people took the survey, 79% said that they are still using the device. So that's a pretty high compliance rate for people who were just sort of randomly polled on a given day to complete their results. So so again, now that we know that the important benefits are alerting and giving the attention to the caregiver, we ask people to has the device alerted a caregiver to a seizure? And 63% of respondents said that it did. And then we asked how successful has that happened? Like how if you had to give sort of an estimate of time, how often has the device successfully alerted? And 18% said 100% of the time, which I was actually pretty impressed with. But if you look at the top sort of quartile, the 75 to 100%, that makes up a pretty decent chunk of the amount of people who said that it worked really well. The other thing, on the other side of the coin, though, if you think about sort of the issues or what would make someone stop using it, false alarm rates were considered the highest reason why people had issues, and also said they would stop wearing a device because the false alarms may outweigh the benefit that they get from the alerting. And so that's also a really important point for the developers to hear. And also, I think the other thing that a lot of people complain about is dropped pairing with their phone or their device, or failure to detect the seizure, which I put on this slide just because a lot of people said it worked pretty well, but there was still a fairly sized minority of people who said failure to detect seizures was a reason they would stop using a device. Okay. In terms of what types of alerts were most valuable, and again, this is information we wanted to give to the device developers so that they understood the community's expectations. The most common valued alert was an audible alarm on a device itself. And if that wasn't the case, then people expected a text or a phone call. And we had the email as an option too, or others, which people could fill in. So some people reported they wanted, calls to first responders, but majority of people were comfortable with an audible alert on the device or being contacted via phone or text to their loved one or their assigned caregiver. And then, I think this is also another important point because it goes back to that safety concern, which is that we ask people if they ever experienced a seizure or an event where the device sent them an alert and they thought it prevented an injury or possible death. And more than half of people said yes, which I think just really corresponds well with the result that a lot of people are looking at these devices as a peace of mind and a safety, and a lot of the things that Tom has already very eloquently described, but that sentiment really is felt amongst the community. We also ask people what would motivate them to continue wearing seizure tracking devices, and this goes back to another thing that Tom mentioned, and also something that we're thinking a lot more about now after these conversations and after this meeting is detecting nocturnal seizures, which is a huge concern amongst the community. And right along with that, hand in hand, is the reduction of SUDEP risk, which is actually, and this is not surprising to people who use these devices, but that is the main motivation. And so we need to be very mindful when we make labels and talk about devices and what they do and don't do for the community to understand how we can communicate SUDEP risks. But also a lot of people just wanted improvements in daily living, and then a good amount of people also reported seizure prediction as a important piece, and we have seen that continuously as a trend at the Epilepsy Foundation since we started polling people about these sort of daily living surveys since about 2016. And then, so switching gears from sort of the questions about how you use devices or what the benefits are, we also asked people how their device was paid for. And 5% of people say that insurance covered their device, which is very, very low for all of the benefits. I mean, if you look and you say half of the people felt that their device had prevented injury or death, and then you look at the device prescription, how it's being paid for, and it's 5%. Obviously, there's a lot of gap in how we should address that. And so 44% said that they just paid for the device, and then 51% mentioned that it was covered by another organization or grant, which is, again, an outsized response, but we did, partner with the Danny Did Foundation, and very thankfully, they're able to provide families with these grants that can give people access to these devices and prevent potential injury. So we also wanted to get a sense of how people receive information about the things that are causing the anxiety or their motivation for a detection device. So we asked about SUDEP, and we asked people where they get information about SUDEP. And the majority of people said that they found out themselves, which I think in the meeting in April gave people the clinicians in the room a lot of pause, because obviously they want their community to hear about these kinds of really important issues in epilepsy in a setting where they can ask questions and participate. And so in that room, we all talked about how we can commit to more clinician-led conversations about SUDEP and devices and information to help people make decisions about devices that might work for them. And that's actually a work group now that we've spun out of the roundtable for this year, and very grateful to the folks who are participating in that and can work on developing those materials as a result of the survey. But again, we also had the same conversation about devices. So, most people do their own research, which makes sense, and that's okay, but we want to make sure that we're pairing that with really meaningful and personal conversations that they can have with their doctor to make it very customized to their needs. And when we think about the desired sources of information, a lot of people still want to hear. We ask sort of, where do you expect to hear, or where would you like to hear about these kinds of topics? And they do want to hear from their clinicians. So I think what that tells us is there's more work to be done to really give clinicians the information that they need to have those conversations with the folks that are in their practices. So the key themes of the survey were, one, that improvement on caregiver quality of life is so important, and it's always so humbling to speak right after Tom, because you hear of all of the amazing research that Tom has done for his own family, and really we want to be able to extend quality of life to the people who are also tracking and monitoring as well, and that people mainly purchase these devices for the detection and alerting. So the caregiver, again, is the person that wants to be tracking these things very carefully. And that's true relative to other things we also asked about, like better seizure counting or sharing with their healthcare team. And then people are still finding out about SUDEP on their own. And that is something where we want to be able to do more for dissemination of information. And a lot of people want the devices, but they can't afford them. So that's also a critical barrier that we're continuing to address. And the Epilepsy Foundation, along with all the partners who are on this call, have been working on ways to engage with advocacy around getting approvals for both insurance, but also Medicaid and Medicare. So as cost is still a significant barrier to use, so 44% of people are self-pay, as we said. In terms of what happens next, again, we really wanted to say, how can we make this very actionable for the next year of work that we want to do? So we use this information to inform next steps. And really the importance of what we need to do now is, and the people who are also on this call are working on this, is getting this information out to clinicians, which means we need to publish the results of the survey so that the community, the clinical community, can see the sort of themes from this survey, as well as how we can use what we've learned here to develop guidelines and inform payers of the importance of the caregiver quality of life, as that is the main benefit for the community, as well as that's the main benefit that the community identified, and also that we can drive adoption of coverage for these things through guidelines as a way to get payers to get on board with paying for these things. And finally, I think this is also something we're thinking a lot more about this year, is the nocturnal seizure reporting. And, Tom already covered this too, but a lot of it is still remaining to be a mystery in terms of active reporting during sleep. And we've had lots of conversations that have been really productive in terms of getting guidelines out there. And so this really needs to be addressed through not only means like this, where we can disseminate information, but also the research to show what can be effective at seizure reporting during the nighttime. And so with that, I'm going to now segue to Teresa, and or shoot it back to Tom. I'll let you.
No, that's great. I just wanted to thank you, Caitlin, for putting that together, and a lot of really good feedback from the community, and publishing the article will be really important, and hopefully translating this to a guideline to come that improves access. So thank you for pulling it all together, and now we can turn it over to Teresa for her comments.
Couldn't unmute, sorry. Can you hear me? Yeah?
Yep, all good.
Okay. Caitlin raised a great point on people wanting and needing this to be reimbursed. So what is needed from the payer perspective for the reimbursement of these tools? So there's a number of different things that payers look at. One is FDA clearance. So in this case, it's primarily a 510(k) software as a medical device clearance that the payers are looking for. This means that a clinical study has been done to get the FDA clearance, that it's been reviewed, and from a payer perspective, this is a viable technology for reimbursement. Clinical evidence is very important. Typically, this may be the FDA study, additional registries, but the evidence that this is working is detecting seizures with specificity and sensitivity that's reportable. They also look to the professional society guidelines. In this case, it would be the American Academy of Neurology, American Epilepsy Society, and the International League Against Epilepsy to look for evidence of recommended use in actual clinical practice. And then they also look at the economic impact data. So what are the savings? Money is more important, I would say, to payers than quality of life. Quality of life plays a role, but it really is all about, can you reduce the total spend related to this individual through the utilization of these tools. So if you look at what are the seizure detection devices currently with FDA clearance, there's two, both wrist-worn, the EpiWatch, and the Empatica EpiMonitor. And you can see that, from the FDA submissions, you have the percent of tonic-clonic seizures detected, the false alarm rates reported, the slightly different form factors. Empatica has built their own device. EpiWatch runs on the Apple Watch, and both are subscription. So there are other products available. They are not FDA cleared, which creates an issue for payers. They view these kinds of non-cleared devices as consumer or health related and are far less likely to reimburse for those. The professional society guidelines are critical, and AAN and AES do not currently have guidelines. Why are they so important to payers? This is really the way that they validate that the clinicians that treat these individuals have reviewed and endorsed these kinds of devices, that they're clinically relevant, that they are actually should be part of the standard of care, and they're likely to be adopted and used by clinicians. It also provides for the payers this evidence-based justification. So they feel that, with the FDA clearance and the guidelines, that these devices have been evaluated, a appropriate risk-benefit analysis has been done, and that this actually has an impact on patient outcomes. So these are the kinds of evidence that Medicare, Medicaid, and private insurers look for to support this coverage decision. Without these, the payers often classify the device as experimental and will deny the claim or simply won't cover it. The International League Against Epilepsy, the ILAE, does have a current guideline, and it was around the use of wearable seizure detection devices, particularly for tonic-clonic seizures, as Caitlin mentioned and Tom mentioned. Tonic-clonic seizure detection and focal to bilateral tonic-clonic seizures have been the focus of devices to date because they have a recognizable pattern that the algorithms can be trained to. So these guidelines emphasize the clinical validity of the devices and their potential to improve safety, particularly when patients are unsupervised or sleeping in a room without a co-sleeper and somebody isn't right there to hear and respond to a seizure. So the significance here is that inclusion in the guidelines would validate the clinical value and accelerate the pathway to reimbursement. For the US payers, however, the ILAE guidelines are not likely to be enough. It's an international organization. The US payers like US guidelines. And so what we're working on with the group that Caitlin mentioned is to get to AAN guidelines that would be utilized by the US payers to reference. This is just an overview of what the ILAE guidelines look like. They're saying that the devices are particularly useful for patients, who are unsupervised, where there's a safety risk. And they're recommending the use of these devices, but also qualifying it with the need for further research. So this is considered a somewhat softer guideline. But then they are saying that device validation, in order to be considered reliable, devices should be validated with a multi-center study that provides a significant number of seizures and patients. So typically those are the studies that are done for FDA submission outside of the US. That would be for CE mark and other regulatory submissions. And then the important detail that ILAE included was the real-time detection, that they should have real-time seizure detection and a predefined seizure detection threshold and the ability to alert the designated caregivers. The other piece that the payers look for is the economic impact. So does the use of these devices have an impact on the healthcare costs for individuals with epilepsy? We know that individuals with epilepsy have about a $9,000 on average higher cost annually of just regular care than a person living without epilepsy. What we looked at here, and this was an Epi Watch analysis done to try to understand if you are using a device, what is the potential impact on the use of that device, and how does the cost of the subscription and the investment in the Apple Watch, if you didn't already have one, what's that cost relative to your acute incidences of healthcare? So that's things that happen as a result of the seizure. So if you look at sort of the cascading cost of care, the longer a seizure goes on, the more expensive it is. So if you look at less than 5 minutes, And you have a device and you're able to respond rapidly with rescue meds, with a magnet swipe, whatever the appropriate action is, you can then potentially reduce the cost of medical transport if an ambulance is not called and not needed, and the ED visit. Look at the costs of those. And this is just on average based on historical studies. There's a significant cost to be transported by ambulance and visit the ED. More than one single ED visit reduction would pay for the subscription of the majority of these devices. So there's a significant opportunity here to reduce that acute cost of care. And then you can look to the right. The longer that seizure goes on, the more expensive the therapy is, going to hospitalization, an ICU stay for status, and then an extended stay. So, you can quickly escalate in terms of acute costs related to seizures. So then what is needed, though, is the actual data. So this is a model. This is a hypothesis. Now what we need to understand is for users of these devices, what was their cost of healthcare prior to wearing the device? What does it look like post-device? And be able to share that with the payers to really validate that investing in this and paying these costs for individuals for these detection devices makes a ton of sense and actually financially makes a lot of sense as well. So that's the work that we're starting to really sort of rally around and get both healthcare centers, neurology practices, and the manufacturers of these devices to collaborate on is, can we get the data that says investment in these for these individuals living with epilepsy not only has a significant impact on quality of life, but also can have a significant economic impact as well. I'm going to stop sharing. So that's a quick overview of how do we actually get payment for these devices and continuing to push forward. In addition, Epilepsy Foundation continues their advocacy. The state epilepsy foundation affiliates continue to push as well. But there's a lot of moving pieces and guidelines, and the economic data are key drivers for reimbursement.
Thanks, Teresa. That's really good. And I know, it's a lot of moving parts, a lot of different factors that weigh into this. And this is helpful to help us kind of understand the landscape. We only have time for a few questions, but one of them I wanted to pose to you kind of quickly, I think, just as a point of clarity. When we say payers, what do we mean?
So payers are Medicare, Medicaid, so that's CMS, so the Center for Medicare, Medicaid. They make decisions on payments for individuals who are Medicaid or Medicare funded. Private payers tend to follow CMS, so this would also engage private payers. So I think it's a broad audience. And then for epilepsy, there's also in the IDD space, there are the Medicaid funded homes and living facilities that would be impacted by this as well. So there it's a state by state Medicaid negotiation where guidelines are really significant.
Okay. And kind of piggybacking off your comment there, Teresa, Caitlin, someone asked, how can the community help to advance a guideline? We know there's published papers and there's data, but what are some ways that the community could help to move that forward and hopefully get down the road towards coverage?
Yeah, that's a really important aspect of getting from where we are now to where we want to be, is hearing from the community. And at the Epilepsy Foundation, as well as all of our partners, we're working on getting advocacy toolkits out for individual states to provide model bill language, as well as information about things that are not covered by insurances. And so it'll be a real big push, community push, to be able to adopt that in particular states. But we are that's in development, and we can share that with the community once it's out, and that'll be a big push. And hearing from the community is so important. We have our advocacy days on the Hill where we talk to policymakers. That's another big component, is making sure that it's on the radar of people that are making these decisions. And then we also, through some of our work, engaging the community in research, provide some additional tools and stories. And one of the things that Tom worked on with us was coming and telling your story to the Diagnostic and Tracking Roundtable, and hearing from the the stories of the families. It does move the needle, and it's really, really important that people hear how this affects families. And even when we spoke with CMS about this, they hadn't even really thought much at that point about caregiver quality of life. And we raised that as a critical issue. And so it's really just getting those conversations started in the room, and it starts with community. So participating in these surveys are really important, but also, amplifying the messages that we can share to get the word out locally is also a critical piece.
The other thing I'd add, not for guidelines, but for payment, even if you do not think your insurance will cover it, submit it anyway. And then when it's not covered, appeal it. So the first round tends to be AI driven and will be just probably denied. The second round, actually, somebody looks at it. So that just starts to build that database of requests for coverage.
That's great. Very helpful. Thank you. And I know there was a few other questions that we didn't get to, but we do want to share a few last bits of information just while we have you. One of which is to let everyone know that the next PAMI conference is coming up in Atlanta in December. The details are on PAMIonline.org. This, as it has been the last several years, it takes place in the lead up to the American Epilepsy Society Conference. So if you may be interested in that meeting, please look online and learn more, or reach out to Allison for those details. Another update to let everyone know that there is now a SUDEP Research Journal Club that is run by PAMI. And this slide just gives you some of the background on that and the next meeting dates, which are coming up over the remainder of this year. It's a really important and innovative approach just to make sure that there's coordination and communication throughout the SUDEP research community, which certainly could include research around devices. And this is just to let everyone know, since we're talking about access and how do we get the devices into the hands of people who need them. One program we have at Danny Did is to provide grants to people with epilepsy and or caregivers if they find a fit that they think will work for their situation. We are not the only organization that does this. Josh Provides put their information in the chat, and there are others. So we thank the entire community for trying to come together and make these devices accessible. Please reach out if we can help in that way. And then finally, just to thank again Cass and her family for sponsoring this webinar. This is really important content to get out to the community. We really wanted to update everyone about this survey and the next steps that come with it, and how the community can help to move this ahead. So we appreciate that this was sponsored by Cass and her family. And thank you for all joining us. Thank you to our panelists. There will be more events coming soon. Please keep an eye on PAMIonline.org to see what's coming next. So we appreciate everyone's time, and have a great rest of the day.